Welcome to Cancer Explained with Central Care Cancer Center. It's likely that someone you know has been diagnosed with a form of cancer. Learn more about specific cancers, their risks, signs, symptoms, and treatment options by listening to Cancer Explained.
Hello and welcome to Cancer Explained with Central Care Cancer Center. My name is Leanne Powers. I'm the Marketing Director for Central Care, and with me today is Radiation Oncologist and President of Central Care, Dr. Perez-Tamayo. At Central Care, we are dedicated to keeping expert cancer care close to home. We have state-of-the-art facilities throughout rural Kansas and in Missouri. Whether you need radiation or chemotherapy, a second opinion, access to clinical trials, a novel treatment, financial counseling, or other supportive services for yourself or your family, even genetic screenings for cancers, Central Care Cancer Center is here for you. At any time, feel free to email with any questions or comments. AskDoctor@cccancer.com. Well, November is National Lung Cancer Awareness Month. So today we're going to discuss lung cancer. It's a very important topic. And first of all, Dr. Perez-Tamayo will bring you in. And I just wanted to, I always think it's important for us to revisit the fact you are a radiation oncologist and maybe just kind of discuss or briefly talk about the difference between what you do and what a medical oncologist does when it comes to not only treating lung cancer, but for any cancer for that matter.
Thank you, Leanne. It's a pleasure to be here. Actually, not only is there a big difference between a radiation oncologist and medical oncologist, but within the radiation community and the medical community, there are specialists in lung cancer. I was trained by the head of MD Anderson at the time, Dr. Cox, who was a doctor recognized for his work in lung cancer. And I co-wrote with him and Dr. Kamaki many papers on lung cancer. In fact, one of the first ones to recognize that certain lung cancers in certain parts of the anatomy can go to the brain early on before they even go anywhere else. So this is an area that I'm particularly interested in and have written papers on. Likewise, in medical oncology, there are specialty areas that have a real affinity to getting the best and the most current knowledge and drugs into the mix, and we have those here at Central Care. We have not only the expertise to treat lung cancer in a very novel and customized way, but we also recognize that even if you need standard treatment, since it is a way of treating patients in the same manner wherever you are, you take the weight and your height to develop the plan for you. It's the same whether you are in Topeka, in Kansas City, in Algoma, Wisconsin. The drug is going to be given to you at the same amount, and it's the same drug. So there's no need to travel. And when it comes to lung cancer, since one of the prognostic factors in lung cancer is your what we call Karnofsky status, or your general status, how well you are doing just in general. And many people, because they have emphysema and other complicating conditions along with the lung cancer, maybe age and weight loss, actually weight loss is one of the major ones, it becomes very difficult to start traveling on a daily fashion if you're needing radiation and weekly or bi-monthly to another area to get treatment when you can have it right here.
I wanted to ask you, when it comes to symptoms and signs for lung cancer, it's basically once these kind of symptoms and signs appear, it might be already too late. Is that right?
Yes, unfortunately, 80 to 90% of all cancers are already in stage 3 or more. And why is that? It's because it's silent. We have now the support of most insurances and definitely of Medicare to do screening if you are a person between 50 and 80 years of age, that you've smoked, even if you've stopped smoking 15 years and you smoke for 20 pack years, meaning that 1 pack for 20 years or 2 packs for 10 years, that you are then qualified to get what we call a low-dose screening CT scan, which basically takes just a few minutes, and they can pick up cancers that are not detectable by symptoms. So basically, when you have a symptom, which usually is bleeding, let's say you're coughing up blood, or pain, usually that means that the cancer has gone beyond stage 1 or stage 2. The difference between survival of stage 1 cancer with treatment is 90% versus stage 3, 10%. So why would you not want to get something that is easily treated, even with just surgery alone or radiation therapy alone, not having to have chemotherapy if you have the opportunity?
And as far as like who is at risk, I mean, this goes for both men and women, correct?
Unfortunately so. It used to be that women were, the lung cancer was not one of the top 5 cancers, and it's crept up to be one of the top 5 cancers in women. It always has been in men, because it used to be really men were more of a smoker than women, but now it's just about the same.
Types of lung cancer, there's a couple main ones, right?
Well, the types of cancers are divided into two big categories. We have the non-small cell and the small cell. They're both very different in the way they're treated, and they're very different in the way the prognosis and the way they spread. So the first thing to do is to identify what kind of cancer you have, what kind of lung cancer, and if there's a genetic component to it.
I was just going to ask you about that. If there is genetic components to the cancers, say like if your father had lung cancer or a sibling, are you at a higher risk for that?
Absolutely, especially if they were non-smokers and you have a cancer that has some kind of mutation or molecular changes that would indicate that this is more of a hereditary type of potential. It doesn't have to be 100%, because sometimes it's just like, you're at the closer to the edge of the cliff, but you may not be, falling unless somebody pushes you. So maybe I'm farther away. Maybe I'm a mile away because I have no cancer in the family, and you may be just a foot away. So if you have enough exposure, let's say at work, for secondhand smoking, or maybe you get radon exposure from your home, or maybe you have asbestos in the home. There are things, even just burning trash, for instance, or a wood burning stove or furnace. Here you are, non-smoker, but you're closer to the cliff because of your family history, and then you turn into cancer.
And you know what? It's not even just the secondhand smoke, or even if you are a smoker, but vaping as well. Vaping is so popular now.
Vaping, in fact, is not only does it is worse than smoking, because it heats up your lung. It's a warmth that goes deeper into your lung tissues and opens up your vasculature. You are actually allowing for more absorption of the bad things that can cause cancer. And not only the carcinogens in tobacco or burning anything, actually, but also there is more radioactivity, polonium in particular, in vaping. So you are actually becoming, it's like you're going to a sauna bath so that you get open pores, but inside your lung. And you're allowing the carcinogens to go in there in a much, much deeper way and farther away. The smokers, in fact, have a more centralized cancer than the vapors, because the vapors can go deeper into the tissue. And if you can imagine the lung being a shrub where the trunk is your windpipe, and then the bigger branches are your bronchial tree. Well, as it gets closer to the edge of the tree, the branches become smaller and smaller, thinner and thinner. But the vaping can get all the way to the thin ones.
That is an amazing visual. Like, I can actually... You just have a way of putting it in a way me, layman's terms, to understand exactly what you just said. And I thank you for that, because it just helps you actually understand exactly, like I said, what you just said.
Well, and the thing about it is that, with the vaping, it's not only the cancer that is concerning, but actually viruses and bacteria, because you're actually producing a bed of a very rich vascular pickup of anything that is surrounding you. So people that are doing this vaping are more exposed. If they're exposed to tuberculosis or anything else, it's much easier for you to pick it up.
And I think it's what's scary too, doctor, is that, you see that vaping is skewing just a little bit younger, and this has been more of an older person's or older generation type of lung cancer as far as it affecting older people versus younger. But do you see maybe that switching a little bit just because of vaping, or?
Well, there is some switching, and there may be some, as we know from other talks we've had, where HPV causes cancer of the head and neck area, of the genitals. It wouldn't surprise me to find out that the vapors are going to have these viral-producing cancers as well.
That's interesting. Again, I'm with radiation oncologist and president of Central Care, Dr. Perez-Tamayo, and we've been talking about lung cancer as November is National Lung Cancer Awareness Month. Dr. Perez-Tamayo, let's talk a little bit about stages and the survival difference between like stage 1 and stage 3 when it comes to lung cancer.
Well, as I mentioned to you, Leanne, the difference is stark. We're looking at a 90% survival for stage 1 and 2, and a 10% survival for stage 3, and 0% survival for stage 4. So, and in addition, it's not so much the survival, which is an issue. Of course, it is a huge issue, but also what kind of risks that you carry from the cancer that are going to impact hugely on your quality of life. So even if that is not something that is on your mind because of age, some people say, gosh, I'm 80 years old. Why do I want to be treated? I'm already stage 3. Well, because if you're going to live 6 months or you're going to live a year or maybe more, do you want to live it intact? Do you want to be independent? So these are all the questions that come into the formula of why we treat. So cancer of the lung is complicated because the different types, non-small cell and small cell, are treated in a different manner. Small cell, for instance, almost uniformly, no matter what stage you are, requires chemotherapy at a minimum, and surgery or no surgery and radiation. But non-small cell can be treated with exclusively surgery if it's stage 1 and stage 2.
What does that surgery look like?
You know, it used to be very drastic because they would do a thoracotomy. You would be in the hospital for quite a few days, if not weeks. But now these days we have robotic assisted surgery or even Da Vinci, and therefore you are almost going to be there for a day, maybe 2. And the treatment is simpler because they don't have to remove as much of your lung. They could do what they call a wedge resection or a lobe. And that's that. Of course, before you even qualify for surgery, they need to know that your pulmonary functions can support less lung. So sometimes even if you're a stage 1, but you have significant emphysema, surgery is not something they're going to do. Radiation is equal in survival, and advantages are much more in that the toxicity is so much less. And since the survival is the same, many times, even if you can have surgery, radiation is an option that people want to take. In the Journal of American Medical Association, which is a very big journal that we all carry as doctors, they have put the survival head-to-head from surgery versus radiation for stage 1 and 2 cancers that are non-small cell, and they are equal in survival. The toxicity and morbidity of the treatment is far less with radiation, and therefore people opt for radiation even if surgery is an option.
I wanted to touch on, again, the screening options for the low-dose CT scan, because it's something that your primary care provider has to order for you, especially if you are a candidate. And you had mentioned in the first segment about how if you are qualified for that, you have to be ages like 50 to 80 years old or have that 20-pack a year history of smoking, or if you're a current smoker or if you've quit within the last 15 years. But it's so important because that primary care physician is the one that has to send that order over to get to that low-dose CT scan, right?
That's right. And the insurances are, for reasons that I don't really understand because it's not necessary, they only accept and will cover you if a primary care physician, and that includes your gynecologist, by the way, gals. If you are a smoker and your primary physician is a gynecologist or a family practitioner or an internist, you can have a low-dose CT scan as a preventative measure to pick up cancers that are yet not apparent by symptoms. If you have the smoking history and you're 50 to 80 years of age, the test is very painless. It is covered by insurance. It actually is not very costly, even if you don't have insurance, you can pay for it, and it's not very costly, and it can save your life. And it's like you would expect to have a mammogram for people that are, just having a screening mammogram because you have breast, not that you have cancer of the breast in the family, or you have a pap smear that is a normal, screening, or a prostate exam with a PSA. This can be part of your screening, normal screening, yearly. Please note this. If you are continuing to smoke or you have this past history, you have to do this yearly, and you should request it by name. Please do not leave your family practice office that you're getting your exam, your yearly exam, without requesting your screening CT of the lung if you're a smoker. This is something that it goes across all cancers. Sometimes people fear that because they are maybe not our patients, that they cannot come in and have us explain things to them. And please feel free to come in and have us explain a CT scan, a PET scan, and especially a pathological exam. Because what happens, the technology, actually the words in the paper that you may receive in your portal are very vague or may not be understood because they are very technical. We can explain it to you step by step. And in fact, we're able to cloud in your images so that you can see them yourself.
That's so important. Again, just be your own advocate and champion of your own health. That's something that you always say. Make this screening part of your own wellness program. Think of it, like you said, as your own yearly checkup or your own yearly mammogram. It's just good information to know. I'm Leanne Powers with Dr. Perez-Tamayo from Central Care Cancer Center, and we've been talking about the risks and symptoms of lung cancer. And let's get into a little bit about prevention and treatment options. And as far as treatment options go, Doctor, I assume it kind of goes with what staging is taking place, correct?
Yes, and especially for the non-small cells. The staging is actually quite important to how you're going to be treated. Stage 1 and 2 means that you have no lymph nodes in your specimen, meaning that when they do your endoscopy, your bronchoscopy, they didn't see any lymph nodes abnormal, which they do biopsy when they do the bronchoscopy through ultrasound. And if the mediastinal nodes, meaning the nodes in the middle along your trachea or your windpipe, are not positive, then you are a stage 1 or 2. However, since that is not the majority of the cases, what happens is that we begin to see lymph nodes in one side or both sides of the windpipe. And that could put you in a stage 3A if it's one side, and a 3B if they are on both sides. That makes you unresectable, meaning that surgery would not contribute very much to your survival, and therefore surgery is out of the question, even if you have good lungs. So, and stage 4, of course, means that it is run into the blood system and it's gone into other parts of your body, including your liver, your bones, and other places. Adrenal glands are often affected. I'm not going to talk about stage 4 because that usually is a only chemotherapy type of scenario. With great exceptions, we see that people respond completely and then they can go into radiation after that. But the second part of the story is what type of cancer you have. There are several histological types in the lung as a non-small cell, and there are mutations which can include what we call EGFR, ALK mutation, KRAS, BRAF, and other ones that will play a role into what kind of chemotherapy is going to be included in the regimen. Usually when we have a stage 3 cancer, we still have a curative effect, and therefore we may be treating you in a concurrent fashion with chemotherapy, meaning radiation and chemotherapy together. And in my, because I am particularly keen about cancers of the lung, we have a higher than national average in cure. And that's because of the training that we have that is special, and we're able to do things that are a little bit more advanced than in most places. In fact, I was the first to publish in the world on something called IMRT, or intensity modulated radiation, which means I'm able to bend the beam to conform to your cancer in a way that is more direct. I can give better doses, and I can exclude tissues that don't need to be treated, and particularly things that are critical like your heart and your spinal cord. They're not part of the problem, so we don't need to treat them. So this is important. It is not what I call a potato head. You don't have, the doctors are not all uniform, and it depends on the expertise of the doctor, not the institution. Because I always find people saying, well, I went to, MD Anderson. Well, I was trained by the head of MD Anderson. I am bringing that institution into my own treatment schedule and ways. So you don't have to go elsewhere to get that same treatment. So it is actually the person that is treating you. It is very much my decisions affect your life.
With the mutations that you had mentioned there, and I know that I had interviewed a patient that had the RET mutation, but it happened with the non-small cell, I believe, lung cancer. But again, that is just the type of a cancer that can just occur. How does that happen, essentially?
Yes, these clinical relevant mutations are noted in primarily the adenocarcinomas, and different ones have a certain percentage, like the EGFR mutation is about 20% of all adenocarcinomas. The ALK mutations are about 5%. So they're not overwhelmingly present, but these mutations mean that the cell themselves are missing pieces of their DNA, and therefore there are certain drugs that are able to turn off the cells and kill them in a better way if you have these mutations in the cell. So they are able to be manipulated and killed with different types of medications than the ones that do not have these mutations. So it is important to have the oncologist, the medical oncologist, make sure that you are not a candidate, that you are a candidate for these special medications if you have these mutations. So all of the adenocarcinomas, it's almost a reflex that we get the type of molecular pathology look to make sure that we have the genetic markers known, and then we're able to see what kind of cancers these are. This is very different than small cell. Small cell comes in a spectrum. You have the neuroendocrine cells, which are cells that are actually embryologically first devised in the neural crest, which is actually what makes your spinal cord. These cells, for reasons, can be in all over the body, and they can start producing cancer in a very slow-growing way. We call those, neuroendocrine tumors that are grade 1s. And then you go all the way to the small cell. Small cells are more wild cancers. They're also known as oat cell carcinomas because they look like oats. And they go very, very, very early in their process into the bloodstream. So that's why even with stage 1 cancers of the lung that are small cell, chemotherapy is part of the picture. And for reasons, again, that we don't know, they often go to the brain, even exclusively. They go to the brain early on. And maybe it's because they're neural crest cells. I really don't know why. They have an affinity to the brain, but they do.
So small cell lung cancers could go to the brain. Other non-small cell lung cancers could go to in the blood, to the liver, to the bone, that kind of thing?
They both can go to the brain. In fact, it's often seen, but not as often as small cell. They all can go to the bone and liver. Okay. But in the small cell, it is when they're earlier in their stage that they go to these organs. That's why chemotherapy is part of stage 1 cancer of the small cell, but it is not part of a stage 1 non-small cell.
Is it the lymph nodes that are taking these cancers then to the other areas in this case?
No, not at all. In fact, this is the 3 ways cancer can grow, and that's everywhere. One is local, meaning that it can spread locally to the surrounding structures or just surrounding lung in this case. Regional, meaning it can go to the lymphatic system through lymphatic channels. These are not blood channels. They actually look like little hairs, and they're full of lymph, which is a fat. And they go to the lymph nodes. Think of them as stations in a train. Train tracks are the lymph ducts, and these lymph channels bring the cancer to the lymph nodes, which are stations. And then there's the blood, which are blood vessels, and the blood vessels are what carries it to the system through the bloodstream.
So when it comes to the treatment options, again, it's just going to depend on where that tumor might be located, whether or not you do surgery, and if you involve a specialist then or from then on out, or what type of chemotherapy and radiation that you would perform, correct?
Correct, and the mutation, everything goes into the equation, the age of the patient. So But again, here, unfortunately, Leanne, as I said, most people are not getting screening, and therefore we're finding these at much later stage.
And that's why it's so important. We can't stress it enough when it comes to that screening. Getting that annual low-dose CT scan among those that might be at high risk can reduce that lung cancer death rate by up to 20% by detecting tumors at early stages when they are more likely to be curable. So the high risk is defined if you're 50 to 80 years of age, have a 20-pack year of history of smoking. That means a pack a day for 20 years or 2 packs a day for 10 years, etc. Or if you're even a current smoker or if you're quit within the last 15 years, you can get that low-dose CT screening. Emporia, Newman Regional Health, Newton Medical Center in Newton, Mountain Garden City at St. Catherine Hospital, even if in Kansas City or the Providence Medical Center there in Kansas City, Kansas, they're all capable of performing that low-dose CT screening as well. Prevention, well, not all lung cancers, I guess, can be prevented, especially if you're not catching it, correct?
Number one, and number two, that some of them are genetic, meaning that you are closer to the cliff and a little bit of a push, including stress. Leanne, actually stress can push you into that cliff, even if you're not exposed to things, carcinogens. So if you are, and if you have that type of family history, you need to immediately let your primary care know and have you sent to a specialist, which is an oncologist that is going to keep aware of you in a different way than a family practice or primary care physician would, because we're looking at so many other things, including maybe a genetic test, which is a blood test. So, and that's not many people, okay? Lung cancer usually is not genetically predisposed, but you have some people that are a little bit more sensitive. But if you're a smoker, even if you don't have any family history of cancer of the lung, you do have the obligation to yourself to get a screening.
Anything else you want to add?
Well, I just say these days with the machinery that we have and the chemotherapy that we have, it is quite easy. So people should not be afraid. Again, not so much for the curability, which many times are highly curable, but because you don't want to lose your independence.
Could it come back? Like if you treat lung cancer in one lobe, could it come back in the same lobe or in another, in the other side?
Well, this is an interesting word that you said, come back, because one thing is it coming back, which means a recurrence. Another is that you have a new primary. Because you have one cancer, you already doubled the risk of having a second one independently of the first, which again is just as curable as the first time. Now, if it came back in the same place, meaning that it started in, let's say, in the upper lobe in the same place and it came back as a recurrence, that's a different scenario. But again, you maybe still qualify for a curative treatment.
Oh, very interesting, Doctor. Thank you so much. Well, we appreciate you taking the time to listen to Cancer Explained with Central Care Cancer Center. With facilities throughout rural Kansas and in Missouri, Central Care offers complete cancer care all under one roof, so there's no need to travel far for the best in care. Whether you need radiation or chemotherapy, access to clinical trials and novel treatments, financial counseling, or other supportive services for yourself or your family, Central Care Cancer Center is here for you. You have a choice. Bringing expert care to you is an important component in the success of your outcome. Being surrounded by your family and friends, that can be the factor that elevates your treatment. Feel free to reach out by calling 800-592-5110 or visit us online at cccancer.com. You can always send an email to askdoctor@cccancer.com. For Dr. Perez-Tamayo and all of our amazing providers and nurses, I'm Leanne Powers. Thank you for listening to Cancer Explained with Central Care Cancer Center.
You've been listening to Cancer Explained with Central Care Cancer Center, offering expert cancer care that's close to home. Central Care Cancer Center has clinics throughout Kansas and in Missouri. Central Care Cancer Center, online, cccancer.com.